This is a video review of basic, simple interrupted suturing for primary care. This is Jay Zimmerman, MD, narrated from Penn State Hershey Medical Center, College of Medicine, here with Jonathan Spiker, class of 2015. Instrument ties demonstrated here use less suture material than hand ties and are preferred for most primary care skin procedures. Typically, I grasp the needle 2/3 of the way back on the needle. Once the suture is loaded on the needle driver, hold the driver with a thumb in one ring, index finger over the neck of the instrument, and ring finger over the other ring. To open or close the driver, push down with your thumb and up with your ring finger. The next step is to enter the skin at a 90-degree angle. To do so, supinate your wrist to go through the tissue. You can go through in 1 or 2 bites. The stitch should be as wide as it is deep. Once entirely through the skin, pull the suture moving towards yourself and pull it through until 2 or 3 centimeters of tail is left. Drop the needle. Create the first throw by making a double knot around the tip of the needle holder with the long strand. 2 twists makes it a surgeon's knot. This increases tension and helps hold the knot tight before the second throw. To do this, pick up the long end of the suture with your left thumb and index finger and hold it above the wound. Keep the needle holder closed but not locked, facing towards the left. The instrument tip approaches the long strand moving towards the person tying it. Both it and the long strand are moved in a clockwise motion to wrap around the tip. Be careful not to pull the short end of the suture through the wound. Next, grasp the tail of the short end with the very tip of the needle holder. Pull the short end through the loops around the needle holder's tip. Keep even tension of both strands as you pull the short end towards you and the long strand away from you. Apply enough tension to oppose the wound. Tension should be parallel to the loop being closed and along the axis of the knot being tightened. The skin's margin should be slightly everted when complete. The suture should lay flat against the wound. The first throw should just approximate the tissue, and subsequent throws must be firmly tied to assure the security of the knot. The second throw is created by mirror image of the first. However, you only need to do a single twist around the needle holder this time. The tension in the first throw and locking it in place with the second knot is critical. For additional throws, repeat the cycle clockwise, counterclockwise. Each knot should lay flat across the wound. Avoid tying the knots too tight. If you leave 3 to 4 millimeter tails, nylon can hold 3 knots, monofilament otherwise will need 4. Knots will slip apart if not correctly tied. Excessive knots do not add security, only time and bulk. Cut the suture to length. There are many techniques for how to start and complete simple interrupted sutures. In a straight laceration such as this one, the first knot should be thrown roughly 1/3 of the way from the edge at one side. The next knot should be 1/3 of the way from the opposite edge. We recommend alternating sides to avoid creating a dog ear. As demonstrated in this video, the sutures on both sides of the wound should be equidistant from the wound margin and of equal depth. The sutures should be no closer than 2 millimeters. The finer the suture, the closer the stitch needs to be, and there will be less scarring. The more tension, the more sutures needed. Place sutures half as far apart as they are across. Cut the tail to length. At the end of the procedure, the knot should be lined up on one side of the wound, preferentially above the laceration where gravity may pull blood down onto the knot. Remember, it is better to remove and replace a poorly tied suture than leave it in place.